We're at the conference in Vancouver, the International AIDS Conference, the IAS, and we're here with Anchalee, who's with the Red Cross in Bangkok, Thailand, and the HIV work and the hepatitis work that's being done there is extraordinary, and the work that you're doing in your devotion to access is heroic. But that having been said, it's daunting with the prices that we have and the gap between the need and the actual cost. How do we bring that down? How do we work with that? Because the drama you see is mostly unfolding, or all over, but certainly and especially in middle-income countries, where they really don't have a way to facilitate treatment.
Yeah, so I think the beginning we should raise the problem to the government, so then they can make like a negotiation with the pharma. So but the problem right now is that, so because we are lacking of the screening system for hepatitis C and also the surveillance system, so we don't know how big of the burden.
Right.
And
you have
also,
no way of knowing what the population
yes,
is.
the population are, and also how high of the prevalence on this issue. So when the pharma, they want to negotiate with the government, they want to know how many patients gonna be treated. So it's like, for example, Egypt, so they can get the lower price because they have a large volume of the patient. But I think in other countries, in developing country, for example in Thailand, at this time, we don't have the real number, how many patients are infected and require the treatment. So we just expect that we have around 1% in general population and around 6 to 10% in co-infection. And in terms of disease burden, we don't have that. Even though the liver cancer is still the number one for men, but mainly from hepatitis B and around 20% from hepatitis C. But with that, although we have the problem with hepatitis B, it's still a challenge in terms of management on that.
So apparently it's both an issue for the government, who has to pay for it, and the pharma, who is going to have to bring the price to a negotiated level.
Yes.
Both of them are quizzing, we need to know what it is, because we're going to have to pay for this at some level, and the other one's going to say we're going to have to bring the price down at a negotiated level based upon, we don't know if we're going to do 100 or 100,000, you know. So this is a real challenge. Could they do a survey of some sort in the hospitals or people where the likeliest suspects would be, the higher risk or whatever, so they could get a sense of it? Because it seems as though there has to be some understanding of what the numbers are.
Yeah,
first,
right,
yeah.
right. So for HIV infected patients, so we recommend all HIV to test for hepatitis C. But for non-HIV, we don't have the system of, the screening system in place yet. I think it just started from now on, that we plan to look at the hepatitis C prevalence in each population in Thailand. And as I mentioned that, so if we have the stakeholder in charge for this, so the implementation would move quicker and in a proper way. So similar to the HIV model, Thailand does a very good job in the HIV treatment and care. So we should do better for the hepatitis C, but it's just the starting of epidemic on that.
It seems though in the press conference we had some discussion about there are models or countries who have created a model of doing a good job of negotiating and coming up with a plan.
Yes.
You know, they said, okay, we have a problem here. We have to solve it. How are we going to get from here to there? And they figured out through negotiation or through generics or whatever it is that they're doing to come up with something. Because we realize with the project, the drugs are not that expensive to make. Yes, they're expensive to evolve through R&D, but we have to get to the real bottom line here. People need to be served with the treatments.
Yeah.
So how would you say we can negotiate maybe a better way to, or at least make evidence to those good models that can be replicated in other countries? Mm-hmm. How would you say we can approach that?
Yeah, I think the first thing we have, so the government need to know that this is a problem. Mm-hmm. And also we have to change the attitude mm-hmm. of other healthcare personnel that the hepatitis C mm-hmm. is really curable disease. Mm-hmm. Yeah. And we have to do more because in the past, I think even in Thailand or in developing country, they think that hepatitis C could not be treated because of the high cost of the treatment. But now we can bring the cost down. But it's not just I don't think it's just the cost issue, but we also have another issue. For example, the registration mm-hmm. of the drug in the country is quite slow, right. and also how to scaling up the screening. Mm-hmm. For example, in Thailand, we have free hepatitis C mm-hmm. treatment with PEG-RIBA mm-hmm. starting from 2012. Mm-hmm. We expect to have around 20,000 patients treated, but in reality, up until now, less than 3,000 patients are treated. Mm-hmm. So we need to do more in terms of raising awareness for both patients and healthcare personnel, mm-hmm. and also in terms of how to have the cheaper or simplify the screening, the monitoring process.
Right.
Yeah, so I think for hepatitis C, in terms of treatment, it's easier than HIV because it's just only 12 weeks of treatment.
Yeah, and then you have a cure.
Yeah, it's a cure, actually. Yeah.
Well, thank you very much, Anchalee. I really appreciate your help and bringing that to light. Thank you very much.